facet disease, right? And so what happens is, the discs are not only shock absorbers, but they're spacers as well. So as those things settle, a lot of times they can bulge out and press on a nerve and cause ridiculous symptoms. Or another thing that happens is those facets now start to ride on top of one another. So they're losing the space, or the facets that are normally oriented here start riding on top of one another, and that kind of sets off the cascade of facet-mediated pain. And so on that diagram down there, with a lot of people, if you'll notice, it says C23, C34, 45, they get a lot of referred pain from those facets. And they know that from back in the late 60s, early 70s. Apparently they were injecting like super hypertonic saline into medical students' facet joints and reliably recreating pain in those areas. So I'm glad they went through that we don't have to do that anymore. But so if somebody, kind of, they can feel like a knot at the base of their skull and it radiates up in the back, a lot of times that's a bad C23 facet. 3-4 would be kind of the middle neck, and then 5, 6, and 6, 7 goes down into the shoulder blade. So if anybody's had PT and they're failed that, and that's to start working, think about facet-mediated pain. So what we do for that is we'll do a medial branch block. The medial branch is the pain fiber that innervates the facet. And most commonly we'll do C3 to C6. And so the reason we do that is like maybe 50% of their disease is at 5, 6, and then 30 is at 4, 5, and then 20 is at 2, 3. So, historically we'd only maybe do 2, and Medicare only pays for 2, but I like doing those 3 because I just get a lot better results with that. So if they get 80% relief with that block, we got to do a second one. And if both of those result in 80%, then we do a radiofrequency ablation. And that's where we take a special needle that has an exposed tip about the size of a Q-tip, and it wraps around the facet, and it heats up to 80 degrees, and it burns the centigrade, and it burns the pain fiber. And it lasts about a year to a year and a half. And so if it comes back, we don't have to go through the blocks again. They can just come in, and we can just repeat their ablation. So I think what's most surprising is you would think that this is really 80-year-olds, and we see a lot of, especially women in their 30s, with pretty significant cervical disease, and then men seem to have a little more lumbar disease. So it does hit people early, especially if you've been in like an auto accident or a motorcycle accident or something like that. A lot of people damage their facets when they're young and don't realize it, and then it starts manifesting in their 30s and 40s. So that's probably the most common thing that we do in the clinic. The other thing we see a lot is radiculopathy. So got another diagram for you on the second page, just to remind you of what those dermatomes are. So, really classic. If someone's like, man, it is in my shoulder, and it feels like an ice pick in there. And they always point to the humerus. That's pretty classic C5, and then down the forearm C6, and so on. So if you've got anybody like that, glad to see them. And you don't have to get an MRI before you send them, because a lot of times insurance will say, well, they got to do 6 weeks of PT. But if somebody's really hurting and they're in a bad way, we just request a peer-to-peer and just tell them they can't do the PT. We got to get the MRI. And they just want it right away. So that's not something that you guys need to worry about if you run into that. As far as treating radiculopathy, I put a little bit of stuff in there, but basically what we'll do is a steroid injection. So in the cervical region, the epidural space is about 4 millimeters at C17-1, and then it rapidly drops down to like 1 millimeter and 0 at like 5, 6, 3, 4, and so on. So we always go in at C6, 7, and then we can get good spread pretty much to all levels from there. Now they used to do transforaminals where they come from the side, but there's a ton of veins in that area, and there was a fair amount of cord infarcts that had happened throughout the country. So the National Society pretty much said no more transforaminals in the cervical region. Just do a cervical interlaminar. So I'll still sometimes get a request for a selective nerve root block in the cervical region, but that's the reason we don't do it. It's full of landmines and people don't really do much. But in the lumbar region, we commonly do transforaminals, and so I'll show you a picture of that. But basically, come from the outside in, docket where the nerve root is exiting, and then put some dexamethasone and steroid in there. When you're looking at radiculopathy, a lot of times people are just looking at a disc, but it could be either a disc bulge or it could be foraminal stenosis, so the foramen narrows up from the disc settling down, or it could be an enlarged facet. So sometimes when people get enlarged facet, it enlarges both anterior and posterior, and there's this area called the lateral recess, which as the nerve roots come down, it goes far lateral before it exits. So a lot of times they're banging on that nerve root in the lateral recess from an enlarged facet or a disc. So oftentimes we'll go at 4-5-5-1 or 3-4-4-5 or bilaterally, but that's the thought process behind that is it the disc, is it the facet joint, or is it a little bit of everything that's hitting them? As far as like, approaches to treating it, they don't have motor weakness and just pain. Pretty much all the surgeons feel like we'll give this a try. And so we'll do one and see if they improve. If they're getting good relief, like 50%, we may repeat it. We'll never go more than 3 in a row. Like they gotta be really, really making strides. Like if we're gonna do a third one, they gotta be like, man, I'm 75%, but I just want that little extra. But if we do one and they're not any better, or if we look at the images, which we always look at our own images, I think radiologists are really overrun with volume and they miss stuff. And that's not anything bad against them, it's just like their work life. So we'll catch things off in that. Maybe our mention, but if somebody's got a really huge disc and we don't believe it's really gonna work with an injection, we'll still proceed because oftentimes they have to fail injections and some of the things before they would get a surgery. But we'll work really hard to get it into a neurosurgeon. We usually work with NSA, so Lockheed, Hajar, those guys do a good job. They're really responsive for us when we get it. So.
What was the third person?
Lockheed, Montalbano, Hajar, all our guys at NSA. The new guys at Luke seem pretty good too. Brandon McGann, we've sent some folks there. They seem pretty responsive. I don't have their cell phone, so it's not quite as good as the other guys. And then Graham Hall, I like him a lot over at Al's, so he does a good job. He's real responsive. So if they have a St. Al's only insurance, we can always go that route. So what else can I tell you? So that's the bulk is axial back pain and radicular pain. And then you guys probably don't see it, but I treat a lot of CRPS. So the thing with that disease is a lot of people, especially the work comp adjusters, they want to see all 7 Budapest criteria. And that's like skin changes, nail changes, hair loss, bone loss, sweating changes, cold limb. The problem is that this is a disease of progression, right? It's kind of like coronary artery disease. It's like, we're not going to treat you until you have a heart attack. It's like, no, let's start early here. So the biggest thing you'll see is they just complain of pain that is way disproportionate from what you'd expect. And that's either post-surgical or just from an injury. And they'll talk about things like, man, I can't even let a sheet go on it. I just barely touch it. It feels like it's on fire. If you see that at all, send them over right away because we'll do either a stellate block with aggressive PT for the upper extremity or lumbar sympathetic blocks with the same thing for the lower extremity. But you can reverse that disease, but you gotta jump out early. Yeah, and then you're kind of, I like to kind of scare them a little bit and be like, you really need to work on your PT and get this thing moving because a lot of times they'll just splint it, they won't use it, and it gets stiff, and they get this vicious cycle. But we've been real successful at unwinding that disease if we can catch it early. But if they've had it for a year and they've been bouncing around a lot, or another thing, like if they have pain a lot of times, they're like, well, let's explore it or let's take out the hardware. Well, now they have like a neuropathic disease and now they take another hit. So it kind of wasn't the thing to go after, you know what I mean? So it's a pretty easy procedure to do and we can get in pretty quickly. So if you see any of that stuff, that's another thing to think about.
You have a big differentiation between that and pain is being mediated by hardware.
Hardware?
Yeah, hardware.
Hardware, I don't, and I kind of defer to you guys and surgeons, like, when is hardware painful? Because I always think about if it's hardware, it's kind of would be more localized, or if there's some kind of movement, but this is more like diffuse. They'll point to the whole hand, it's not really a dermatomal distribution. I kind of feel like hardware is a little more site-specific, but these guys, it's very typical, and then oftentimes they will have temperature changes and some swelling early on, so those are all things to
Let's just say with hardware too, it can be like a mechanical, like they have a cartilage or a tendon,
snap over.
or it's a deep ache, like they complain of a deep ache. It's not like I can't put a sheet on my skin. It's
Right.
like superficial.
Yeah, exactly. Yeah. So that's the bulk of kind of what we treat. But one thing that you would ask me is like, there's anything that I think about, don't miss this, right? And I think the biggest thing that we can improve on as a community is compression fractures and managing those things. So there's this thing in the community that says, well, if they have a compression fracture, don't worry about it, it'll heal. But what happens is that bone is so thin. I mean, you shouldn't break your back when you fall or pick up a suitcase, right? So that's happening. That thing is so thin and fragile that what happens is it rapidly pancakes down, and then it'll wedge, and then a lot of times the back wall will break out that kind of wedges in the back wall, and that's called retropulsion. And historically, they'd say, well, you don't want to kyphoplasty anybody with retropulsion because the back wall is knocked out. It's dangerous. You don't want cement to go backwards. But now they're like, treat it, because if you don't, they're just going to flatten all the way out and retropulse. So I just want to show you guys some images. This is a lady I treated this week, actually, just to give you kind of an idea. So, I mean, you can see like just how flattened it is, and she's got a fragment right there. And that blackness, I'll show you on the plain film, is almost like air in there, but you can see that she's also got a little bit of fracture in the back wall there. And I think this lady's fracture was like, I mean, prior to this, she had 20% height loss, and she came to us 2 weeks, and then we got this, and you can see how much progressed just in 2 weeks. This is just another view, so that's in the middle, that's right in the center of the fracture. You can just see she's just pancaked there, and if we don't stabilize that, this could possibly kind of go out the back wall there and cause real problems. So this is her, and you can see this light area. I mean, that's like almost like air in there. It's just like hollow because it's so, her bones are so thin. You can barely see the outline of these vertebral bodies. But this is the general approach of kyphoplasty. So I'll drop a needle in there, I'll numb the skin right there, or numb the periosteum right there. Once they're numbed up, they're pretty comfortable. We do IV sedation in our clinic. We do sedation twice a week and non-sedation twice a week. So we have nurse anesthetists from St. Luke's that come in and help us. So anything that's painful, we can handle really well. And we've never boxed anybody and sent them out in an ambulance. So far, so good. So that's the trocar kind of advancing into the vertebral body, and then we advance it into that area. And so what I'm thinking about is, I'm like, if I go in here, I might leak out the disc up here. And so then the next thing that comes in is there's this curved osteotome that we put in there that as we advance it curves across there, so it creates a void for the cement to go in, because you don't want it going backwards. I mean, the only thing you don't want it going this way, because that's right where the cord is. So you want to keep it in there as best you can. So there's the curved osteotome going in there, and then here's the cement going in, and you can just see this thing like a balloon. I mean, it almost kind of fills back up, and she got really good height restoration with that. And then this is showing from across, so it spreads all the way across. And then there it is, fully reformed. But if we can get them early, this thing stays soft, and it'll actually kind of fill up like a paper bag. But if it goes for months and months, it'll just compact, and then the only area we can typically get is maybe a little bit here. So it's a lot worse of an outcome. So if you guys get a plain film on an old lady, and just you see any compression fracture and they're painful, we'd love to see them sooner than later. And then we'll get an MRI with stir sequence. And if the stir is lit up, then you know it's fresh and it's moving. If the stir is cold, then it's old and it's not the cause of their pain. What's probably the cause of their pain there is because of that wedge deformity. They got a forward stoop, and it's probably facet-mediated pain, and so we'll block above and below those facet joints to handle that. But the MRI with stir is what gets the.
Do you care? Does it matter how much or how little compression they have? Like if it's just a small wedge?
No. Yeah, even if it's like 10-15%, that's the other thing is like, well, how'd you get this? Well, I picked up a suitcase or fell. I mean, nobody should break their back from a fall. And that's kind of a litmus test. It's like if you're looking at somebody and you're like, if I push this person over, will they break a hip or yep, okay, let's treat it. That's kind of if they're a strapping young person, then we're gonna brace them or surgery or something like that.
So was this a kyphoplasty?
Yep, this is a kyphoplasty, yeah. So vertebroplasty, you just put the trocar in, and then a kyphoplasty, you're creating a void with either an osteotome or a balloon. Yeah, and I like that a lot better. I used to try to do vertebroplasties, and you'd get in there and you'd squeeze the cement, and it would find a fracture line going backwards, and it would go, and then you're like, we just got a half cc in there, and I'm doing hardly anything for us.
So if someone just wants to stabilize it and get better pain relief, you don't have to wait until it compresses, right?
No. In fact, Medicare wants it treated like quickly. Yeah, because they've done a lot of research on it. They found that if you let that kyphosis form, they get postural deformity, especially in the thoracic region. They'll get a restrictive lung pattern. They're prone to more fractures because now their saddle balance is off. So Medicare 10 years ago would resist, and they've totally flipped. They want you to it's all about ADLs, right? So if they're having trouble transferring, dressing, putting on their clothes, that's it. They don't want anything about the fracture itself. Yep. Great question. Right, and then I just to show you, like, I mean, look at this. Look at the postural deformity this lady has now, just from that stupid fracture. You know, if we could have got it when it was looking like that, and it was just lit up on stir, we would see it. And then you look at the cords just kind of bending right over that thing. That's what you don't want for sure. And this is another one. I mean, this lady, she got sent over, and then about 2 weeks after this was done, this thing was gone. Like there was nothing to like go with, and then you can just see what it's done to her cervical spine. This is another old one that she had, but I mean, man, these people are walking around with just translucent bones. It's hard to believe, but that's osteoporosis that's untreated. So I just included this just to show you guys. So this is a radio frequency ablation. So here's the facet joint. The medial branch comes here and it's pinned down by a ligament right here called the mammal accessory ligament. And then one branch comes here, and then the other branch comes down and innervates this half of the facet. So when we're doing 3, 4, 4, 5, and 5, 1, I'm burning at this one, which knocks out this medial branch and this one, and then we're burning here, which knocks out this one and this one. So then down here, when I hit this, it hits this guy and the other half. So that's how the anatomy is, and that's what it looks like. You can do it without sedation. We use a bunch of lidocaine. It's not bad, but some people just can't tolerate the discomfort. So we'll do a little Versed to help them out. And then this is a cervical one. So the cervical region, the medial branch comes back, goes in the middle of the centroid, and one goes up here, and the other one goes there. And then this comes back, goes in the middle, and comes up here and here. So you got this tip right here, and this is what heats up to 80 degrees Celsius and makes a lesion on the sides of the Q-tip. And then this is a transforaminal epidural, just to show you, like, you get it right under the transverse process, and you can just see this contrast allowing the nerve root exiting really nicely, and we're getting it spread medially there, and hitting this lateral recess, as well as the exiting foramen here. And then this guy, even better, this contrast just really lit up the nerve root right there. So that's the key to these, is you want to get it in the right spot, but you don't want to poke in the nerve root. So you just steer it in over there, and then that's what we're doing for those lumbar size. So that's pretty much what I got for imaging stuff. I brought my skeleton if you wanted to look at anything and get any specifics there. But any questions I can answer for you guys? Any of that?
Yeah, I got one. So as far as like working them up for you, you said they don't always need an MRI.
Yep. Right.
If we can get one, obviously that probably helps you.
Yep. Yeah. I just want to. Sometimes it's a pain, for you guys, and it can take resources that maybe you don't have or you're busy. But if you can, great. And we have access to Al's, Luke's, and Treasure Valley.
Okay.
But if you can't get it, or you want to get him in a rush, we can certainly get that done.
Okay.
Is there anything you've noticed in our referral process that we need to do that would be more helpful?
No, I think the only thing is, like, some of you guys have my cell phone. I love when you text me and just say, hey, can you get this guy in quickly? Because, in any clinic, referrals can land on a pile, and then that pile goes in a corner, and, you're somewhere in the bottom. We try to get to them quickly, but if you've got anybody that you want to get, and then Russell Harmony and Parker Olson are the PA and NP in our clinic, they have capacity every day. So they have slots that are open, and we staff it that way on purpose. We don't want to be pinned where we can't get anybody in. I had a lady, a friend text me today with a lady who had a really bad compound ankle fracture, and she's 3 months out, and she's just showing signs of neuropathic pain and difficulty, and we got her in the same day. So that would be the thing. I wish I would have put my cell phone on there. Is there a way you can get that to you? Okay, perfect. Yeah, just like I say, texting is best because I'm in the procedure suite and I'm seeing that all day. I'll just copy it, send it to Haley, who's my manager, and she'll just get it done for you.
I'll add it onto the spine reference tab on the PA schedule with Dr. Bridges and Dr. Danny's cell phone numbers.
Perfect. Yeah, that'd be awesome.
Yeah, both of them, like I said, if there are certain days of the week, just give us a call. They give us their cell phone numbers.
Okay.
So I'll put you on there.
Cool. Yeah, that'd be great. Awesome. Anything else?
Well, I know a lot of the
follow-up PAs, and the people who say, see follow-up, you're doing a lot of MRI reviews.
Mhm.
I don't do these, but do you guys have any questions when you're like going through this with patients about how to best treat what you're reading, or who to send it to, or what the cutoff is?
You review reports or look at the MRIs or what do you?
Either one, whatever
Yeah.
you're looking at MRI or, reading the report, like what, do you have any questions about like who should see what in terms of what you're seeing? Or do you guys pretty much know? Like if it's.
I just know that the radios are under read them.
Yeah.
They never talk about lateral recess. They just, it's perverted in, like, all these genetic changes are just normal people.
Yeah. Clinical correlation. Here's the percentages of stuff that happens to normal people below. And,
Yeah, it's definitely what it is.
yeah.
Because some people look at the report and say, oh, there's nothing wrong with me, right?
Right.
And I look at it, well, you got the center arthrosis here, here, and here, and you have to be irritating those nerves. And
Yeah.
so I would never just base it off the report.
For sure.
Honestly, I usually,
it's the
if
same
I'm
thing.
getting an MRI, I'm sending them
Yeah.
to you.
Yeah.
If we've gotten to that point,
Mhm.
because I usually will try physical therapy and oral meds a little bit first.
Yeah.
But I don't even know if that's, do we even do that at this point?
I think if they're mild, I think that's worth it. Yeah, I think a mildish, Medrol dose pack and PT is good. But if somebody's just got a really roaring radiculopathy, they can point it out to you exactly. They're standing, they won't sit, that kind of thing. That for sure I'd send. And then as far as us versus surgery, I mean, if you see like atrophy, motor weakness, probably surgery. But if you send to us, my promise is I promise I won't like sit on them and inject them and jag around with them like I'll get them in really quick. My field has a reputation for that. Like we'll do these injections on people that have a clear surgical indication. That wouldn't be what we would do. So we would cool them off and then I'd call those guys directly and they're really good about getting them in. So
I was gonna kind of ask a question, but like if you just see severe weakness, things like that, you just refer to the surgeon or?
I think so. Yeah. They can always send them to me after that. But if they got weakness and atrophy, that's usually something that injection's not going to fix that. And that's a great point because to do surgery, if they don't have weakness, they have to fail injections and PT and meds. If they have overt weakness and reflex loss and atrophy, they go right to that. So I would say that'd be a better referral for sure. We had a guy come in the other day. His whole intrinsic muscles of his hand were just completely atrophied. He couldn't. Yeah, we were like, how long has this been going on? He's like 6 months. We're like, had no surgery. So yeah. What else? I mean, you guys probably never see spinal cord stimulators at all, but we do that quite a bit. So we do that for they've had a fusion and they've got chronic radiculopathy afterwards, and nothing's helped them with that. Or if they've had a crush injury, multiple surgeries to their limb, and they have CRPS, and they're not responding to the sympathetic blocks, or just peripheral neuropathy, they do really well with the stims. So we put in 2 leads in the epidural space, and they try that for 7 days, and if they get at least 50% improvement in their pain and reduction in their meds and better sleep, then they qualify for it. We're implanting. Also for elderly people that they've got radiculopathy, and the surgeons are like, we can't operate on you, you're just too sick or too osteoporotic. They're a good candidate for a spinal cord stim too. So, but we would certainly try radiofrequency ablation and injections first. We wouldn't go to a stim. But if they're failing that, I'll often send back to the surgeons, and they'll say no, they're not a surgical candidate. That's an option. But you guys probably won't see those folks, but just to put in your knowledge base.
Are there any insurances you don't take?
Just primary Medicaid, but we take secondary Medicaid, and then we're on all the Medicare. I think the only one we're not on is Molina,
Okay.
TRICARE, everything else. VA is funny, they won't authorize it unless you're on some magic list. So I don't get, if they have straight VA benefits, we have trouble with that. But if they're TRICARE, no problem. Yeah, what about you guys? Are you guys taking anything?
We don't take some TRICARE.
TRICARE.
Uh-huh.
Yeah.
Okay. Yeah, I think we're pretty much similar. Yeah.
Check us select.
Cool. Yeah, exactly. Thanks for having me. Yeah, it's really nice meeting you guys in person. And like I say, if you need anything at all, get that cell phone and give me a ring.
Thanks guys for coming. Thank you.
Wife's doing great still.
I was gonna ask. That's awesome. Cool.
She said, say hi and thank you.
Okay, good. Yeah, that's great. Yeah, that's great.
She did, yeah. I need to come in, maybe get some cassette logs.
Yeah, everyone.
Okay.
It's different.
Yeah.
I mean, she's not my guest about it. She's like, you just gotta come in.
Yeah, they're